introductions. And Renee, would you mind introducing yourself again to the group?
Sure. Renee Bolio Banks, Indigenous Jaganashimang, Zibikwe Indigenous Indigo. I'm Gasagaswa Jamaica Gandunjiba. My birth name is Renee Bolio Banks, and my spirit name is River Woman, and I'm from the Leech Lake band of Ojibwe, the Leech Lake Nation. So I've been at NACC for about 4 years, and I'm really glad to be here. Miigwech.
Thank you. Dr. Rabi?
Hi, I'm Kari Rabi. I'm a family practice and addiction medicine physician here at NACC, and I work in our MET program.
And Nikki?
I'm Nikki Jardina. I'm the infectious disease nurse at NACC, and I've been here off and on since 2016.
And Tina?
My name is Tina. I'm the harm reduction manager here at NACC.
And I'm Lindsay. I'm the community and tribal engagement specialist here at NACC. So I'm going to do some announcements. I'll share my screen here. All right, so welcome to Midwest Tribal Echo. We're the opioid use disorder education and treatment series. Today we have Edward I knew I was going to mess that up. Eddie Krumpotich, talking about first in the nation, Minnesota's unexpected leap into progressive harm reduction. A little bit about NACC. So we're an FQHC located in South Minneapolis. This is a list of all the services that we provide. These are the current opening positions at NACC, and our website is down at the bottom. Feel free to go onto the website to look at those job descriptions. Some session guidelines, please, no protected health information. If you could let us know who you are in the chat function, that would be great. This is a new platform that we're going to be switching to December 6th. And then some announcements. So our next ECHO will be November 15th. That's decriminalization of sex work. And then, excuse me, December 6th, Transitions Clinic Network. This is a list of other ECHOs that we recommend. And then we do offer CME credit to those who are eligible. And then I'm going to stop sharing this and we'll get to Eddie's presentation. All right. Thank you, Eddie, for being here with us today.
Hi, everybody. My name is Edward Krumpotich. You can call me Eddie. I'd like to start off by saying thank you to each of the individuals in this room who came today. Many of you may know my story. Many of you may not. Many of the individuals in this room saved my life when I was myself out on the streets of Minneapolis and in Minnesota. Many of you took me in when I had nowhere to go, and were creating a space of love and tolerance and empathy long before any of this began. And in my gratitude today, it's just an honor to be here with each of you who have, you know, helped bring a son back to a family and a advocate to the community. And if there's anything that I can give in today's talk, it's that it is the community itself that is the most important. And this really ends up being a grassroots effort. So I work as a consultant for the National Harm Reduction Coalition and for the Drug Policy Alliance. I started, however, these ventures right off of the streets. I had been denied medications as prescribed for ADHD to treat partially my mental health and also my SUD, going into a sober home. And I had been to 40 treatment centers, and count that one. It still takes a long time for me to be able to count that, but 40 treatment centers, 30 detoxes. I was somebody who could not get it. But as Thurgood Marshall says, others have got to pull you up by your bootstraps to allow you to see for who you really are. And it took a long time for me to get there. And some may call it an awkward path. I just call it a path that needs to be more accessible. And I've been seeing it happen across the state of Minnesota. And so my leap into this came from individuals like yourselves and communities like NACC and Indigenous Peoples Task Force and Leech Lake Band of Ojibwe and Fond du Lac, which is, I live in Grand Rapids, by the way. And so it does not go without mention that I live on stolen land. And so I respectfully say that to each of you, knowing that I stand with each of you on your journeys, wherever you may stand today. I also the chair of the Minnesota Harm Reduction Collaborative. The collaborative was started last year, and we were a bunch of Minnesota harm reductionists, leaders of various organizations across the state. I started the organization to discuss policy. What I saw as a barrier to many of the policies that were happening across the state of Minnesota and nationwide was there wasn't a grassroots or person with lived experience dedication to what we were discussing. I felt left out of the conversations, as I've discovered many of my fellows had also felt this way. And so we created a space for people with lived experience, grassroots level organizations, BIPOC led, BIPOC focused, to be able to discuss what was happening in policy. And we didn't have a direction at first, and this is truth. We talked about various things, but we didn't know that we'd be writing policy. And so we'll talk a little bit about what we discussed, how this matriculated, and how we did become the first in the nation. And that's a mere bypass to the work that was done by many organizations that are in this room today. You can go ahead and change that for me if that's okay. So today we're going to talk about a few things. So the Minnesota Harm Reduction Collaborative, who are we? What do we do? What have we done? What's the harm reduction movement look like? The problem. So there was a problem that lie in much of the data and the science, as well as disparity rates. We knew that in the state of Minnesota, for instance, you were 10 times more likely to die of an overdose if you were Indigenous, and 3 times more likely to die of an overdose if you were Black. These disparity rates were the worst in the nation and continue to be in various metrics across our Indigenous and Black communities here in the state. Excuse me. And much of what we dedicated ourselves to doing last year were to try and help this, but we'll discuss that more. And we'll discuss HF 2041, which was a provision that used syringe service providers like they have at Indigenous Peoples Task Force and at NACC, Rainbow Health and others, and expanded access. And we'll talk about what that looks like, why access is so important, and why we do not want to become burdensome to communities that know, talk, and discuss together, because that is what this law did. It opened up communal dialogues without restriction. We'll also talk about how this was a true grassroots effort, the legislative strategy behind it. We'll talk about what it's like to actually do a grassroots effort strategy. And we'll talk about some efforts that may be ongoing. So who are we? We are a collaborative of individuals and organizations across the state. We are led by physicians groups, nonprofit organizations, people with lived experience. For example, you don't need to be a member of a 501c3 to be a member of the organization or to have an influence. We are community-led organizations and community-led groups, specifically Black-led and Indigenous-led, developed last year to make a indent in policy specifically for harm reduction. So we found spaces to talk about grassroots level efforts related to harm reduction, but it didn't seem like there was really a legislative push, or dare I say a legislative influence, which is something that I firmly believe in needs to come from the bottom up. What we've done, we provided an inclusive environment for individuals who are even currently using to have an impact in the legislative space. Many places across the nation discuss the following: what is happening on the ground needs to be what's happening in the legislative offices. Unfortunately, that doesn't necessarily get as much airplay as it needs to. What we did as a collaborative is came together to discuss what the data looked like, what was happening both anecdotally, qualitatively, and quantitatively, and actually moved through that with policy. We made policy for the current moment, which is something that needs to be done more often. We had a lot of people moving in different parts, and we had avenues of different strength, and we'll discuss that as we move on. And what have we done? So, long story short, while I was using methamphetamine, and I make this abundantly clear, so I've been to 40 treatment centers, and while using methamphetamine with partners in the collaborative, we wrote together the nation's first legalization of drug paraphernalia and drug residue. So what I wanted to emphasize to you is that the person that you are, the participant, the family member, the person that you're looking at today, may very well be someone like myself who can use methamphetamine, who can use fentanyl, who can write a bill, and can talk to somebody across from them about something that's both salient and relevant. Not only is that not a stretch, these were my medicines that helped keep me alive. So I have a 7 on the ACE score. My ACE score is way up here. But what wasn't on there is the color of my skin and where I come from. I came from a rich, entitled family on the East Coast, loving, but as an individual who identifies as gay and with lots of trauma in the house. Trauma, the language of both change and pain, would catch up. And without methamphetamine in my life at times, and without services that met me where I was at with empathy and kindness, for example, Indigenous Peoples Task Force case managed me myself, and I speak as a white man here. That was one of those change agent moments for me that did not understand how somebody could be so kind. And that law that we wrote together reflected both that. And these were the questions that we needed to start asking ourselves is, what were communities doing that we weren't seeing? Was this pervasive? And how can we express this in legislative action? And I believe that the collaborative did that together. Next slide, please. So did you know, if you worked in an SSP, now there had not, I'll be frank about this, there had not been a case out there that I believe had been prosecuted. However, let's say you worked at a nurse's station during COVID-19, frontline heroes, and that was the media metric, right? These are our frontline hero individuals. We saw them on TV every single day. Imagine if you worked at a community center with syringes and paraphernalia that were dirty, quote dirty, terrible word to use, but that were quote used. Not only is the stigma that is entrenched in you, but you are not only a frontline hero, you're not protected as one. You're not talked about. You're not relegated as one. You're looked at as less than. And the reason I say that is because even in my mind's eye, that's how I view it. The law didn't protect what you were doing. We wanted to make sure that there were simple protections that for community health workers, we could protect them. So we knew that that was one avenue for change. The second one was that our SSPs were delivering illegal materials. So imagine going to somewhere to a doctor's office and getting a medication that was illegal from a doctor. Our community health centers were delivering illegal pieces of paraphernalia, not only regarded by the CDC as life-saving, because we all know that the statistics, right? So if you use a syringe from a SSP, 50% less likelihood of infectious disease, 5 times higher likelihood that you'll go to treatment. I myself got HIV from a dirty syringe. I mean, excuse me, a used syringe. I did not have access, and I almost died from the seroconversion of my own HIV infection. These are life-saving places with life-saving implements. And what we began to find was this thing called paraphernalia exclusivity. So one of the key points to this is that when you legalize one thing, remember that you're also excluding another. In our adventure to legalize syringes across the country, one of the things that we forgot was all the other forms of paraphernalia, including things like smokables, tins, cottons, cookers. And in that, what we've seen in the last year is a transition to smoking, evidenced by the community health organizations that have been discussing this at the ground level. I've been making site visits for the last few months, so I live in Grand Rapids, I drive down to Minneapolis just to come in and visit with everybody. But I do this because I wanted to hear what the conversation was saying. And this was done, not on anybody's time, this was done on my own time, because I knew that the grassroots level conversations were not being had together. And what did I hear? Participation was up, transition to smoking was happening. And so what I just said is landmark for a few reasons. Number one, if we see those trends continue, a transition to smoking would be a drastic reduction in infectious disease, as those transition points for things like syringes and hepatitis C, bloodborne pathogens, are way less on smokables. And secondly, the science is clear that if we increase participation at a community health level, you are begin to curbing the metrics which are typically the only ones studied: overdose, mortality, crime. We were missing underneath. And so right now, as we are speaking, organizations that are on this call are seeing a transition that we're beginning to see across the country. And we are the only state who is now getting funding from the state to pay for things like smokables, that we can begin to make an indent in these. And we'll discuss why that's so important. The next part of the laws that didn't make sense, among the many, was that rural Minnesotans lacked care. So in the cities, I've been to, I was an adult shelter connect individual. I remember my very first day when I got my very first car in a blue jacket and a red underhood. I was so embarrassed. I'll say it now, but I was met with such kindness and love. I've been to a lot of shelters in my day, and in rural Minnesota, they don't have access to these services. These services, unfortunately, don't exist. So for an SSP, for example, to distribute paraphernalia, Sue Purchase and Harm Reduction Sisters are scaling their services to use vans to distribute throughout Indigenous lands and throughout the range here in northern Minnesota. These services aren't enough. We had a 10 syringe handicap, for example, that needed to go, because if you were open at the right hours and the right transportation at the right time, you could maybe get somewhere from, for example, Hibbing to Grand Rapids, but that would be rare. So we went to the pharmacy board and were able to do that. And we did that with grassroots level individuals like myself, who had no degrees behind them, no political experience, but a lot of lived experience as well. Another thing we found was that drug checking, we saw a pretty common conversation. Legalizing fentanyl test strips. Remember what I said earlier, is that when you legalize one thing, you exclude another. So we saw a problem. Fentanyl test strips were the common discussion, but what about everything else? And xylazine was one of the most important factors here. In some of the site visits I did among places like Hennepin County and St. Paul, we discovered that 8 in 10 reports came back positive for xylazine. There have been different variations from those statistics. However, that was a large number. Last year, we removed it from the paraphernalia law altogether. We wanted to make the law pliable and adapting to future dialogues, novel substances, for example. There are over 2,000 substances, 2,000 that are reported throughout the world. How many different variants of fentanyl, for example, are reported? If we had stuck with just fentanyl test strips, it would have limited us to one brand, to one drug, to one trajectory. Last year, we were fortunate enough to get rid of all of that. So places like Harm Reduction Sisters have their first FTIR machine, which are testing the quantity, quality, purity of these substances so people can stay alive. That is the number one most important thing that we can do, is keep people and communities alive. Next. So these numbers are pretty telling. From 1990 to 2020, there was a 161% increase in drug offense of our incarcerated populations. And these are Black, Brown, and Indigenous individuals to a escalated amount, right? So the chances of one being arrested if you are Black, Brown, Indigenous are far higher than if you look like myself. I've been using it since the age of 19 years old. I'm a teacher of the year in the state of Maryland with a master's degree paid for by my family. And I used meth since that time. You can guess that if I looked a little different, that my story would be a little different too. And not only is that indicated both anecdotally, but this is what we see in our jail systems here in the state of Minnesota. I have been able to move by the system purely because of things that are not in my control. So how did we tackle that in our incarcerated population that was increasing? We saw an increase since the 1970s of 342% up to 2015 of overdoses. And in a similar period, a 282% increase in incarceration. The most telling statistic that we went to the legislature with last year, those numbers were doing this. Why was our opiate admission for treatment right here? We were dying, we were going to jail, but we were not getting help. First line of defense, unfortunately, was a jail cell, and we needed to do something. And so we wanted to follow the science and the community's guidance. And we'll discuss how we did that moving forward here in the future. However, the evidence was clear. We also had an HIV outbreak that occurred in places like Duluth, Minneapolis, and St. Paul. What I want to emphasize is that the law itself wasn't the solution. Much of what was already happening on the ground was the solution. And we'll discuss a little bit about that moving forward. But many times we got caught in a conversation that we were beginning to hear last year in the last few months, and it came together rather quickly. Next slide, please. So what do we know? Overdoses are up, infectious diseases are up, access and treatment. So we are the Minnesota model. Quote, we are the Minnesota model of treatment. Why are we not having an increase in treatment with the escalation of fentanyl cases here in the state of Minnesota? How is that possible? We reformed comprehensive assessment the year before, so we didn't have monopolistic intentions from different places people could walk in. What was missing? Well, I'll take you to a statistic that's said often, is that only 10% of people will find treatment. Only 8% of those individuals will find 5 years of recovery. And of those 90% that are left, those numbers still stayed the same with treatment levels. They weren't moving. So we surmised that those 90% were not coming out of the shadows due to shame, fear, and stigma. When I walked the streets, I didn't have to face the similar fears that my brothers and sisters did, but I'll tell you what, the number one fear that I had on my mind was being locked up. Number one. I would drop bags, I would drop paraphernalia, I would throw them to the side, I would do anything that I could not to. How could we change that conversation, that very small conversation, to this, I don't have to, and put it into the conversation with you guys, where the magic, I'll call it, where the magic happens. Those were the conversations that science was talking about, that communities had been dialoguing, and that we had been discussing for a long time that weren't being met under the law. What the science says is very clear, that if the first touch that somebody who uses substances has to an empathetic, community-led organization, their chances go way up. We all know this, but we were handicapped here in the state and across the nation. And we knew that we could do something about it. We just didn't know yet exactly what it was going to be. Next slide. So the first part of the bill is rather simple. When we define something, we give it legitimacy under the law. So MDH had already began a syringe service law to define the law as it was and give definition to syringe service provider. We want to give legitimacy to things because it matters that people know that syringe service programs are public health initiatives and they are not enabling outfits. That is the talk. So we wanted to give them legitimacy under the law. What we began to find, though, is that if we did not keep it open-ended, we would restrict much of what harm reduction sisters was doing. So we added 3 words, which may include. These are free public health programs. I visited most of them, in the cities. And I got to tell you something. They're not what you would see as like an Abbott Northwest or an HCMC outfit. You're not walking into a doctor's office. You're walking into a community partnership where people know who you are. A discrete place where people can go into a separate door sometimes and feel okay enough to ask for what they need. So not only are they getting legitimacy, which may include the following. It left it open-ended so not every community outfit needed to fit the definition. Let's say I'm a community-led organization in Red Wing, Minnesota, and I want to start from the ground up, and I have nothing. Grant funding, we all know how that works. It's like, oh my gosh, we have to apply for another grant. We know how slow those are. Infectious diseases move now. And if I wanted to build an SSP, I would have been handicapped by that definition because it would have had to fit each of them. We were able to argue successfully that which may include was important because it would allow the community to be adaptable to the time. So individuals with lived experience, for example, could also deliver. They could possess hypodermic syringes in this case and not be held liable. We wanted to tackle infectious diseases, and we did so in a pretty drastic way, even with the beginning part here. Next slide, please. Low pharmacy barriers. We went to the pharmacy board where we got a great partner. We basically said, look, if 9 to 5 is when Walgreens is open with no transportation, how is somebody, I used to inject whatever I could find next to me. It did not matter if it was used or not. Come to find out that the agency that many of the individuals would say, oh, he's just using because he's a, quote, druggie. Because of syringe service providers and harm reduction across the state, my transition into a healthier use pattern came when I went from injecting to smoking. I learned that when I walked the streets and into harm reduction outfits who said, maybe try this. Not only did my mental health improve, but I began 1 year later, my longest tenure of what I would consider to be continued abstinence. I have not been back to treatment in 3 years. And that was all because we increased access to these places without barriers. And that's what we did with rural Minnesota. We got rid of the syringe requirement. If you walk into a Walgreens on a Monday, you can ask for as many as you like. As many as you like. And this does not mean that it has to all of a sudden meet a barrier from, the unfortunate part here is that it's not a mandate, but we trusted the communities that pharmacists knew each other. And we have a great partner at the Minnesota Pharmacists Association as well. Next slide, please. We talked about drug checking and how important that was in paraphernalia. Across the country, we had heard from different, I'll call them talking heads, but that paraphernalia restrictions need to go. I used because I needed to use drugs. I'm a person with a master's degree. I'm not supposed to use drugs. I'm not supposed to be homeless. I'm not supposed to have HIV. I'm not supposed to struggle for ends meet. I'm not supposed to struggle for anything in life. But I still had a needle in my arm. I still had a smokable, and I still was scared to go to jail because of it. I was also born with ADHD and a 7 ACE score, which made me astronomically at a larger potential for getting a substance use disorder. I was untreated as a child, which leaves me 8 times higher likely for this as well. Would you blame somebody who used insulin for a disorder that has begun in the factories of what we would consider to be attachment to behavior? Diabetes is something that is given to us in our genetic profiles. ADHD and SUD start in the same place. So why were we criminalizing the person for picking up meth and protecting the ones who kept insulin? Each of us had no chance before we picked it up, none. And I chose the one that I needed to get rid of all that trauma. So what we thought was that unfortunately, syringe-only requirements were excluding smokables. Most people smoke. And frankly, and this is true for every drug that we see, most people do not qualify for SUD. Most people do not qualify for somebody who has substance use disorder. And that also goes for things like fentanyl and cocaine and methamphetamine. There is a higher addictability process that goes through with them. However, it is not the norm. So when we excluded syringes in that same vein, we were missing every other modality of use. We were restricting it. So we became the first state to say, what if we legalized everything? And then we had the big conversation. How did we get rid of that fear of going to jail? It's not going to be easy. I mean, I still have it today. Today. It is a trauma reaction for myself that my freedom would be taken away from me. And I feel even in this moment, I feel disingenuous saying that, but that trauma reaction lives in me, which is what prevents me from seeking help, like my fellows on Metro or my fellows in northern Minnesota. So what did we say? We said, how can we bring somebody back to Native American Community Clinic? We have to decriminalize the drug within the paraphernalia. And this was not meant to just bring syringes back. It wasn't just one of those come, go. We want you to bring back because we want you to distribute and lower infectious disease. It was to follow the simple science of community. Come back because we love you. You're accepted where you're coming. You are loved here. When you go to treatment, without saying there is an implicit bias that what I am supposed to do is give up everything. You may love me at the outset, and that is true. But if you can relate to this, it's like your entire body and mind are being sucked out of you because you've got to give up something. If I go to Indigenous Peoples Task Force and I'm using, and you hand me a box of syringes, guess what happens? I'm okay using. You have agency to make your choice. And we're here for you because we actually care. That was the science of community. It was being spoken in the languages of every study that we saw. There wasn't one study oppositional, so the language was not meeting the message. And we said, if we get rid of residue, we allow communities to conversate without having to arrest with a speck. And yes, I mean this, a speck of fentanyl was a 5th degree. And what does that entail? 5th degree possession brings on probation. It brings on restriction for housing, for employment, for gainful employment. It brings in on car for licensure. Tell somebody their first time getting a 5th degree before a couple of years ago when we revamped the law, that their life would be handicapped. And how do I know? Because I worked for a staffing agency who hit the deny button over and over and over again to people who had 4-year tenures at places like McDonald's, when in my entire life, my longest tenure was 3 years. These were harder workers. The workforce was being left out with little chance of increase in what we call workforce stature, because the law handicapped people from moving forward. So we said, how do we get them back to the conversation? We make the drug legal, whatever it is, inside the paraphernalia. What we've seen since we started this, and this is not causal, I want to make sure to tell you this because this is just the first couple months, are increased participation, new clients. How do I know this? Because I hit the ground running. I went to each organization across the state. I interviewed, I asked questions, because that's where the conversations were happening. And they were all speaking the same thing. We're seeing this happening. These were the numbers we were hoping to impact right away. Next slide, please. So what did we want to do? We say follow the science, but it's really simple. We wanted to go from the jail to public health. Our jail systems, I mean, you know this, do not have MAT. I've lost my best friend, I've lost my brother, and I've lost my best friend anyway to coming out of the workhouse day 2 without MAT and passing away from a heroin overdose. In some studies, it shows in the hundreds of percent increase. A couple of years ago, we had an entry to try and get MAT into jails. We're trying to do that again. Suboxone, Subutex, methadone are gold standards, not because of what we look at as one metric, which is abstinence from, I like to tell people to get that out of our heads. For example, I use stimulants still to this day. And in abstinence, 40 treatments, I was homeless. I had no bank account. I had lost my family, everybody I cared about. The state of Minnesota paid $15 million. Today, I use scheduled substance, namely Adderall, methylphenidate, and Vyvanse. I have jobs, family, positions that where people love me. I have my first apartment. I have a cat. I have plants. These were the metrics that we were missing. Personally, I use a thing called stimulant replacement therapy that is still handicapped under the law. But these were the access points that were being missed. How could we increase access to allow individuals and communities to speak for themselves? So what we did was we wanted to make jail not the first option. We had conversations with police around the state. We made those conversations open, yet what I would call cognizant of what we would see as traumatic responses. Our state had been hit horrifically by the murder of George Floyd and by many of the police abuses that have been happening across our country. And these conversations were difficult. We made sure to allow people to be invited into these conversations, but we also made sure to have them in a way that it was evident. And so what we did was we talked to the collaborative about them. My first day doing the collaborative, I got to tell you, was one of the toughest days that I've had because these conversations came up and I did not know how to navigate them. I was out of my league. And so I asked around for help. And I've got to tell you that what I began to find was that everybody was speaking a similar language, was that we want people to be included. But how we did that, we didn't know. And one of the things that we were able to do was have those conversations in a way that not only met the moment, but stood with communities that had been horrifically ravaged by police violence over these past decades. It was very important for us to make sure to have those conversations and to acknowledge of the hurts. And we did so both in front and behind. So those were evident from the outset. We wanted to make sure that when police were pulling somebody over, they were giving somebody to a syringe service provider or a community clinic. It's hard to emphasize, I think, that like many times people are like, well, what's the difference? I just spoke with the Itasca County Police Department today, who are great partners in this and are seeing many of the same things that our communities are seeing. It's this fervor to do something. And each of them are speaking the very same language. It's allow the communities to do the work. Stop getting in the way. Stop getting in the way. Today's conversation was really important. I discussed some of the law and how when we upped the bridge to residue at our lowest level, what we've now done is created a barrier between fifth degree possession and allowing communities to discuss with one another what needs to happen. Without knowing it, what we did here in Minnesota was create a communal language. The paraphernalia law, while it seems rather simple, allows for a large discretion where communities can begin to have those conversations without interjection from the state level. We don't want someone just going to jail anymore for a speck of fentanyl. And I made it clear today that somebody who's using 0.5 mLs of fentanyl falls under personal use. And given the current laws here in the state of Minnesota, what we know is that that amount of use may mean life and death. I share this because everybody needs to know this. Everybody. I have lost too many friends without that knowledge. And what I was amazed to hear is that that work is now being done and has been being done. And it needs time to matriculate in our communities. So what we did was we started referral networks. So I know this sounds really simple, and I can tell you this, as we were writing this as a collaborative, many of this was not on the mind's eye. But I remember on the street, if I got good shit, I was coming back to good shit, if that makes sense. Pardon my language. But good shit also kept me alive. Good shit also kept me motivated with trustworthy individuals. And those same referral networks were the ones that were saying this community center is helpful. These were the community conversations that were being had. What we've heard lately is that the fentanyl dialogue is changing on the streets. How do we know? Because we went right to the streets and asked. We're seeing a turn back to methadone. This was something that was unknown to many individuals, but was given to us as a lead. And this was given to us by the street. We're the ones giving this information out because we're one of the only individual states having that amazing conversation. People with lived experience are hearing what is happening right now. So why does that conversation matter? Well, that's one of the most incredible conversations, because if we see change in the fentanyl dialogue, a synthetic analog, a synthetic opiate, we may be seeing a curvature back to where we would see as a homeostatic place for opiates like heroin or methadone, which was a normalcy. The change in fentanyl and how much it's changed over the past couple of years can sometimes be a little bit intolerant. It's like me getting a batch that kept on changing. It was hard for me to take that on. These are the conversations that only somebody who used substances would know, but how important is that conversation in our discussion of safe supply? If we know people are turning to methadone over fentanyl, and we're being told this by the street, then it is the street that's keeping our communities alive, and they trust us with that information. That right there, everybody, is safe supply. And it's happening. And that's because you're doing the work. And I got to tell you, it's really difficult when you realize on like this, on the policy end, that it hasn't been measured. But it's measured in conversations. And so in that graph, around the graph, what we saw is those referral networks were hugely important. And then, like myself, those individual states have changed. I trusted someone to tell me where to go. They said where to go and who to see. I came back and I changed. One of the biggest parts of what I would call my personal journey was when I went from injecting to smoking and passing the syringe in that line. It took every bit of energy, hope, and change state that I had in me. And I got to tell you, everything that they say would not happen for somebody, quote, like me, did. I made the healthy choice. I wanted to stay alive. And wouldn't you know that it was less than a year later that I found what I would find to be, for at least for myself, a homeostasis that worked for me. An apartment, my last treatment, working at Applebee's for my very first job, and then working as a suicide de-escalator for 988. A year prior to that, I was on the streets with a needle in my arm and then transitioning to smoking. And what was I doing? I was being allowed to make that change. community clinic said, Eddie, well, it was a late one. Actually, it was at Pride Institute. I was on methylphenidate and I felt less than because I was like, well, I can't take stimulant if I'm a stimulant user. And one of my therapist said, Eddie, you may use meth the rest of your life. And it hit me like a ton of bricks. I was like, wait a second, I'm not going to use meth the rest of my life. And it hit me because it was the first time I had ever heard from somebody, Eddie, it's okay, man. You don't have to be some teacher of the year. You don't have to be anything. You are good enough using methamphetamine. You're good enough, man. And it stuck with me over and over again, every cold night. And that was the empathy for one change. 40 treatments. And all it took was somebody to say, Eddie, you're okay. Every single person that we touch could be another one of me who could be writing law. And not only do I believe in it, I know it to be true. And so what we want to do is allow those voices to speak their talents and to remove the barriers from them maneuvering through our system, which unfortunately has them locked up without housing and without employment. I was able to graduate off of what I would call food assistance. And people go, congratulations. That also was embedded into my genes, where I came from. So it's what conversation were we going to have when we went to the legislature? And it was the one about people being left behind and turning back to community. And that was that wheel simply. Now you can look in every study, by the way. So every SSP study that's come out from Kingdom Come from 30 years ago, yes, they are, in scientific terms, they are all, some, not all of them, but most are statistically significant with what we would see as positive attributes. All that means is that communities were doing this discussing and we weren't shaming people. That was it. Simple. So how did we do it? We did it with very little words. We did it from the ground up. So when I say that I was using methamphetamine while writing the law, not only was I doing that, I was talking to individuals in our collective while doing it, who were helping my own mental health at times of need. You would know what that's like. But if I told somebody at the legislature that I was using methamphetamine while writing the law, what do you think that would look like? It was a perfect example of what each of us can do together and have been handicapped to do. So what paraphernalia did was it made a pivot. It made a pivot back to you. I had been to 40 treatments and made some amazing relationships. And not only that, I remember when I say my gratitude speaks, it speaks enormous volumes. When I came to Minnesota, I had nothing. I left teaching. I got up and left for the first time in my entire life. I knew nothing about living. I had been given everything except for a bad deal of the deck with when it comes to trauma and substance use. But I had to fight for everything, and not one time was I ever resisted by the people here. It goes to show the amount of love that exists at the community level. When I do community visits today, I mean, I got to tell you something, I'm actually excited. And I was called lazy and all these things as a kid, but I got to say, we meet once a month in a collective together as a collaborative, all of us. People are looking to us now as the movers and shakers. And who are we? We're not incorporated. We're not a 501c3. We are people of lived experience and people who serve them, who looked at the grassroots level and said, what can we do? Next slide, please. So what we wanted was the increased participation. What we did not expect, or I did not expect, was the transition to smoking. We heard this conversation. Oh, they're just going to be selling it out there. The funny part is, and I hope we all know this, is that even if somebody is selling a bub, that is exactly what we would want. They're distributing paraphernalia to somebody who needs it, and they're engaging in a community dialogue. That is a win upon wins. And in Minnesota, we're the only state being able to do that without handicap. The only one. We said we trust you. We had 2 community partners in Senator Uma Verbaeten, Claire Uma Verbaeten, and Aisha Gomez, who represented districts in the Twin Cities, and were 2 women of color who represented the movement and were active participants and leaders while we were doing our work. Not only do they participate
Eddie,
today.
I'm sorry to
Yes.
interrupt. I just wanted to give you a time check. We're about 2 minutes to 1 o'clock. Sorry
Oh
for
my
the
goodness,
interruption.
I talk too much. Yes, my apologies, guys. It's
No,
hard for me to
that's fine.
surmise other than this. I would say it's just so you can open up to questions, and I'm welcome. I'll be here to stay if somebody would like to talk, but I've now been around the block with policy for a while. And I can tell you these conversations don't happen often. They don't happen often. The data isn't being gathered. Communities aren't having these conversations. Why? Because nobody has been asking. Well, I can make you one promise, is that I am always available if you ever need to discuss something related to either policy or something that's trending or otherwise. And if I don't know, somebody in the collaborative will. I have a lot of help. This was true grassroots effort. And I guess last thing, guys, is that I do want to emphasize how grateful I am to be in this room. That it is very, it does not go without saying that you saved my life during some of the worst moments of my life when I had nobody. And I trust you that you guys are doing the work. Just want to say thank you. We got another session to go. And if you'd love to hear like a one-on-one or talk about policy, that is what I'm here to do. Please reach out to me, because I won't let something go by without it going through the community first. I can make that promise. I really appreciate you having me on.
Thank you so much.
Yes, thank you.
Does anyone have any final comments or questions? Has a little extra time?
I just want to say that I really appreciate the perspective. Eddie, I appreciate you coming and speaking with us, and we enjoyed having you visit us a few weeks ago. Thank you very, very much. It was good to hear your presentation.
It was great to finally meet you, Dr. Robbie, after about a year, and just get to see the facility. It was awesome. It was awesome.
There's a question from Catherine. How did you begin this journey of making new law policy?
I got tired of hearing no myself. I was let go, kicked out, put down to, and I just got tired, and I did it pro bono. I started with me and my cat and a lot of anger. And I just said I wouldn't give up until change was done. And it really was one of those stories where it just came right off the street. I also taught it for a living in high school history, so it kind of fit it, but I was sick and tired of being told no.
Thank you so much. There's a lot of thank yous in the chat. I think everyone really appreciates you sharing your story with us and the work that you do.
The
Yes.
feeling is not only mutual, it's I appreciate the invitation today.
We hope to see you again.
You as
Yes,
well.
and thank you. Thank you, everybody, for joining today. Have a great day.
Thanks, Eddie.
Thank you.
Thanks, guys.
Shaka.